give, they go to their fellow and say, you want to go to Los Angeles tomorrow? And so Dr. Lee, who is actually a physician, and I think epidemiologist,
I got my master's in public health.
Public health, and sort of like, actually I did something like this in the 90s and said, I've had enough medicine, I'm going to go get an MBA. He said, I've had enough medicine, what would be interesting? And he landed on informatics for some reason. And today he's going to talk to us about, you put your talk away, good, using biomedical ontologies to make sense of complex electronic health records. And this is a little bit of a switch from our analytics. It's because the original speaker couldn't make it yesterday. We wanted him to be in with the architecture and other things. But it would be remiss of us in this meeting not to pay attention to how we actually build semantic architectures and try and relate these things. So over to you, Dr. Lee, and thank you very much for coming at such short notice.
Thank you very much for the introduction. I hope you don't think of this as a bait and switch. So anyway, as mentioned, I am a general internist. I practiced and taught medicine for about 10 years or so before I had a sort of mid-career crisis. Some people may say I lost my sanity and decided to pursue a doctoral degree in biomedical informatics. And the area of research that I ended up deciding to focus on, and it was interesting to me to listen to the last panel discussion, which had a lot to do with physician trust and things like that. I ended up going into biomedical ontologies because a lot of the people at Stanford, and especially in the biomedical informatics department, were doing a lot of machine learning stuff. And I just didn't trust it. I didn't know what they were talking about. That could have just been my own brain, the way it works. But ontologies made sense to me. And so I kind of gravitated very naturally to that area. And so what I'm going to do is I'm going to talk a little bit about the work that I've been doing with Dr. Das. I'm speaking on his behalf. I've been in this lab for the last 3 years. This is my fourth. And we're going to be talking about some of the work we've been doing with biomedical ontologies and trying to make sense out of very complex EHR data. I think it's a given. Actually, Suchi, I don't know if she's still here, gave a much better sort of presentation about this than I think I could have, talking about the complexity of medical record data. And as we know, electronic health records are becoming increasingly implemented throughout the United States and hospitals all across the country. And one of the things I happen to be interested in is treatment patterns, clinical practice patterns. And for those of you who are physicians, especially if you're interested in health services research, one of the things you already know is that variations and variability in clinical practice patterns has a number of adverse outcomes, such as increased healthcare costs, poor health outcomes. That's not me by any chance, is it? Oh my God, it is. Excuse me, I'm sorry. I thought I shut my phone off. Yes. Poor health outcomes and decreased efficiency in terms of healthcare. One of the nice things about electronic medical records is that they give us the ability to look at practice patterns on a large scale. And so what I'm going to be talking about is our way of looking at treatment patterns from the medical records. Now, at Stanford, what we have is something called the OncoShare project, which is essentially a large-scale effort to capture predictors and patterns of breast cancer care. I'm focusing in breast cancer here. At Stanford University, it's a collaborative effort between two different healthcare institutions. The first is Stanford itself, the hospital and clinics, and the second one is the Palo Alto Medical Foundation, which is a community-based clinic center located right next, literally down the street from where Stanford is located. The OncoShare project was initiated a few years ago with a generous gift by the Richard and Susan Levy Gift Fund, and currently contains de-identified clinical data on more than 18,000 patients from the EHR at both institutions. In the process of trying to put the data together and try to analyze what we have, we've run across many barriers. Some of these things have been discussed earlier. And here what I do is I just highlight some of the problems that we've had to address. The first is that even though both Stanford and the Palo Alto Medical Foundation use the same electronic medical record system, Epic is their vendor, they have different terminologies. And so they don't really talk to each other. And so if you go to, as we have done, go to, say, the people at the Palo Alto Medical Foundation and say, well, listen, how do you guys describe this set of drugs or this set of labs or whatever? It turns out to be completely different than what we do here at Stanford. So multiple terminologies are just not done in a very systematic way for treating data, and this is even within the same vendor. The second problem, of course, is that knowledge about plans is not captured in treatment-related data, and we have to infer this stuff. And so anyone who's worked with electronic data before, any kind of data, knows that you don't get a sodium level that says this person's hyponatremic. You don't get an EKG that says that this person had a heart attack. You have to infer this stuff. You have to take the data and then work it backwards, essentially. And then the other thing that we've come across is that there's really no way that we can automatically compare one person's treatment history to another. We can do it by hand. We do it all the time. A lot of epidemiologic research is done that way manually. But in terms of doing it automatically, there isn't a very good systematic way of doing so. Our approach to this problem has been to use ontologies, and for those of you who are relatively new to ontology, like I was a few years ago, and I'm not claiming to be an expert, but an ontology essentially is a taxonomy that has multiple link types, each that has a precisely defined meaning. So the example that's given here is a clinical research study, and you can look at the solid bars as saying, well, the solid bars represent is-are links, okay, and the dotted lines represent part of links. And so you can say basically, as you work your way down, a controlled study, a case study, is a case study, which is a clinical research study. And clinical trial studies can be part of study arms, and a clinical trial study is also a clinical research study. And there's a hierarchical nature to the way that this taxonomy is structured. Most of us who have heard about ontology before usually think about it in the field of philosophy, where ontologies really have to do with the study of what entities are and how they exist in reality. The computer science folks have used it basically to develop a schema that allows us to represent different domains and allow computers to basically reason about these domains and the relationships that are between them. What's kind of interesting to me about this picture here, my advisor put it up, I'm not quite sure what he's trying to say, is that, and this is why I say this, because this is the classic story of the elephant and the multiple wise men, right? And so they, one feels the trunk and says it's a snake, and the other one feels the tail and says it's a rope. And the point is, none of the wise men got it right. And here's the computer science view of that, and the computer science view didn't get it right neither. And so, but what they did do is they emulate the humans. So I'm trying to figure out what that means if my advisor's trying to tell me something. As it turns out, ontologies have a very wide interest in the biomedical field, and there's been lots of ontologies, large standardized ontologies such as the gene ontology, such as SNOMED CT. I think some of this was discussed yesterday. I wasn't able to be here, and the point is that biomedical communities are very interested in engaging, developing these things. And at Stanford, we also happen to have the National Center for Biomedical Ontology, which is essentially a large repository of different ontologies for multiple clinical domains as well as biological domains. And they provide tools so that you can access those ontologies and use them in a reasonable manner. Now, how can we use ontologies in the OncoShare project? Well, one simple way, which I'm not going to get into too much detail with, is using ontologies to sort of resolve differences in terminologies. And so this is just an example of a paper I presented a few years ago where I suggested that ontologies could be used to model quality of care processes in cancer care. We could create a virtual medical record, which is based off some work that was done years ago on the SAGE project, develop a care process record out of that, and then make models of clinical events. I'm going to spend a little bit more time talking about how we can use ontologies to help us compare treatment histories, which is one of the things that we're very interested in doing in terms of analyzing data. And so the example I give here is, here's a set of women who have breast cancer, and each of them have different treatment procedures that have been done with them. Mammographies, mastectomies, chemotherapy, radiation therapy, so on and so on. Different kinds of surgical procedures, chemotherapy procedures, medication procedures, and so on. One thing that ontologies let us do is they let us compare similarities of clinical events. So, for example, in each of these women, they all had the same surgical procedure. One had a mastectomy, another one had a lumpectomy, another one had a bilateral mastectomy, another one had another lumpectomy. How would I compare all these women together, okay, just in terms of a single event that they happen to have. Well, one way we might try to measure semantic similarity is to take the coded terms. Okay, you go into an electronic medical record and you say, well, let me pull out this, and this person had a lumpectomy. I happen to know that. The other one had a modified radical mastectomy, and the other one had a radical mastectomy. And if I wanted to say, well, how similar are these things to, say, some guideline recommendation? Okay, let's suppose I went into a clinical practice guideline. I say, how similar is a lumpectomy to another lumpectomy? Well, the answer would be fairly obvious. They're identical to each other, and so I say they're exactly similar to each other. If I wanted to compare, say, a modified radical mastectomy to a radical mastectomy, I might go to a clinical expert, okay, and then have that clinical expert look at it and say, well, you know, they're about the same. Okay, so I'll say half. Okay, it's a heuristic, clinical heuristic he happens to use. But when you start saying, well, let me compare a lumpectomy to a radical mastectomy, okay, well, how many clinical experts are you going to go to? How easy is it to do that? And so what we need is, we need something more than just asking experts to do this stuff. We need some kind of principled approach so that we can say how similar is a lumpectomy to a radical mastectomy or any kind of procedure to any other kind of procedure. What ontologies let you do is they let you measure the similarity. And there's actually a very large literature in terms of ontology-based similarity, semantic similarity measures, where basically you can take concepts, okay, within a structured taxonomy such as this, and measure the distance or the similarity between two different concepts. Okay? And there's a variety of methods to do that. I'm not going to get into it, but usually they involve some sort of either shortest path, graph-based method, or they use some kind of term frequency method, or they use some kind of information content method, or they use some combination of the three. And more recently, what I've been seeing is that a lot of it uses some combination of some sort of shortest path graph algorithm weighted by the information content that happens to be in there. So the idea here now is that for at least single event procedures, okay, what we can do is we can take a whole bunch of procedures and we can run it through some sort of standard ontology. Okay, there are many out there, as we've discussed before. And we can apply a metric. And what we get out of this is we get essentially a lookup table. Okay, so now we can take a look at all these different procedures, okay, compare them to each other. And without having to go through the computational process over and over and over again, we have a single lookup table that says, hey, if I have this procedure and I have that procedure, then guess what? This is great because now I can say they're about this similar to each other based on some reference ontology that I'm going to choose. However, there's some problems with this. The first problem is that a lot of times these large standard reference ontologies that are available for public use are not necessarily designed for the application that you happen to be using for. So the example I give here is a drug ontology from the National Drug File. Okay, and let's suppose I was a researcher and I happen to be specifically interested only in HIV medications. And what I wanted to do is I want to say, well, you know, let's take a look at, SQV, standard, antiretroviral drug. All right. Well, if I take a look at and basically the top just shows from the NCBO what the National Drug File looks like. I've made a graphic out of it. Okay. And it turns out that SQV is a kind of HIV protease inhibitor, which happens to be a kind of protease inhibitor. And this is all fine. The problem is that there's a lot of other terms in there that, frankly, I don't need. All right, and the reason this is important is because, remember, a lot of these semantic similarity measures are distance-based in terms of the number of hops to get from one thing to another. And so you have a lot of terms in there, then you're going to end up getting a similarity measure that may not match what you think it was going to match. Well, you could take care of that by pruning the ontology, okay, and there's a lot of research that's been done in terms of ontology pruning. You could just get rid of the extraneous terms. Okay, but if you get rid of the extraneous terms, you still have another problem. Because here I've gotten rid of the extraneous terms, and it turns out that now I have protease inhibitors is a kind of HIV protease inhibitor, which is, SQV is a HIV protease inhibitor. But the HIV protease inhibitor is not necessary anymore because I've gotten rid of all this stuff. Structurally speaking, it doesn't belong there. Okay, because it's an extra added level of distinction, all right, that is no longer relevant to me. And so what we want to do is not just figure out a way to prune the extraneous terms. We want to figure out a way that we can remove, okay, added levels of distinction that make sense in the larger ontology but may not make sense in the application that you happen to be using. And so some of the work we've done on this is basically developing the pruning algorithm. And my advisor did not like the name I chose for it, Ontoprune. So it makes me think of various bodily functions for some reason. But anyway, the onsoprune is a very, very simple approach to pruning an ontology so that it more closely matches what an expert might have come up with. And basically what it is a recursive bottom-up algorithmic approach that you apply to hierarchical taxonomies. And given a set of procedure terms within a hierarchy, what you do is you just find the least common ancestor for that particular term. You prune all the branches and terms that are not in the subhierarchy of that least common ancestor. And then you basically work your way up. And what you do is you say to yourself, well, look, once I've gotten rid of all the extraneous concepts, does my parent concept have one or two branches? If it only has one branch, then you say to yourself, you know what? If there's not a need for a distinction, then I'm just going to remove it. And if there is a need for a distinction, and other words, it has two branches or more, I'm going to keep it. And that's all there is to it. I don't have the slides for the results, but we did evaluate this against 3 different clinical domains, and we evaluated against 3 different reference ontologies that we chose from the literature. The domains were in hypertension, HIV, and heart failure. And we looked at this with different graph-based similarity measures. And basically what we found was that the result compared to a non-pruned tree performed much better in terms of what we think experts might have come up with in the different clinical domains. And so what this does is it provides a way for us to come up with a similarity matrix that can be used as a lookup table that would presumably match what the needs are of the application developer. And particularly because you're applying this algorithm against a large standard ontology, regardless of who you are or where you come from, whatever, as long as you're using the same ontology and you're choosing the same set of terms, you're always going to come up with the same set of scores. So I've talked about semantic similarity of treatment events, and now I want to get into how you extend that so you can talk about sequences of events or treatment histories. So let's take a look at the example that I give here. Suppose I am a researcher or a clinician, and I go to a clinical practice guideline, breast cancer, and I say, well, I'm interested in women who had a lumpectomy followed by some radiation therapy, followed by CMF, which is a chemotherapy regimen that used to be pretty popular with breast cancer patients. And then after that, they got tamoxifen for therapy. And so what I might do is I go to the clinical database, and what I want a ranking of patients who are similar to this ordering of events that I just had. Okay, and what ideally I'd like to see is that when I go to the database and I do my search, not only do I get a list of it, but the most similar patients up at the top and the least similar patients at the bottom. And so I have some way to score, okay, how similar they are to this particular treatment sequence that I happen to have. So when I looked at this problem, there were a couple of sort of clinical insights that I decided to apply here. Okay, and the first insight is that the ordering of the sequence really matters. All right, and I put an arrow here just to the first one to say that the first the first treatment sequence in the sequence matters, but I could just put it for any one of them. And the point is that if I, for example, in this example, I look at a lumpectomy with radiation therapy with CMF and then tamoxifen. If I take the lumpectomy out and I say I only want people with radiation therapy, CMF, and tamoxifen, it's a different kind of patient you would do it for. All right. The first one would be somebody who, standard maybe stage 1, stage 2 breast cancer. Okay. And you go ahead, you do this is a treatment sequence that would make sense for that particular patient. But if I take the lumpectomy out, doing radiation therapy and then giving chemotherapy doesn't make any sense for somebody who has stage 1 cancer. Okay, you're something that you're going to think about more advanced cancer, someone who has a large tumor, maybe they're getting neoadjuvant therapy, who knows? Okay, so the point is that there's a clinical interpretation, there's a different goal that's associated, and so the sequence of events is very important here. The second thing is that a lot of times clinicians, when they look at data, when they're searching, they say, I want to find people who have a treatment sequence that's similar to what I'm seeing here. Okay, they don't necessarily want to see everybody, all right, who has, all the way from the most similar all the way down to the absolute least similar. What they really have is in their mind, they have some sort of threshold. Okay, they're saying to themselves, I want to find people who are maybe 50% similar. Okay, 75% or 20%, whatever it is. Okay, but there's some cutoff in their head. Okay, some sort of heuristic cutoff that says that I want these people above, and I'm not really that interested in anyone below that. And then, as I alluded to before, we'd like to have some sort of scoring way to say I can compare two different treatment sequences. And what I'd like to do is ideally come up with some summary score, okay, for this particular patient here compared to the treatment sequence I'm looking at. Okay, and in this case, the summary score I'm going to do is very simple, just average everything out. Okay, so I just take this, average everything out, and assuming that all the similarity measures that I did between treatments, okay, are standardized to be between 0 and 1, I'm guaranteed that when I do comparisons of treatment histories, okay, from one treatment history to another, that it also is going to be anywhere between 0 and 1. All right, and the idea being here that 0 means that the two treatment sequences are absolutely unrelated to each other, okay, and 1 being they're essentially exactly the same. So the way I implemented this is an algorithmic approach that I call the local alignment tool for clinical histories. My advisor happens to like acronyms a lot. Even though he's a psychiatrist, I think he might be a cardiologist in waiting. And so basically we call this LATCH. And the inputs for this particular algorithm is that it takes a comparison pattern that we happen to be interested in. Okay, it could be something from a reference guideline, evidence-based best practices, clinical practice guidelines, whatever you choose. We have a database, presumably that's kind of cleaned up already, of longitudinal treatment histories. We have the scoring matrix, as I've discussed before, of the different treatment procedures, which is derived from the ontologies. And then we have an optional heuristic score threshold. And what we want to get out in a rank order is a locally aligned treatment sequence that has starts and indices, and has a semantic summary similarity score between the treatment you happen to be interested in and the one that's returned. And the algorithm is very simple. It basically says take the first comparison procedure and then just search through everything, okay, in the database and look for anything, all right, that matches within that minimal heuristic score that you happen to have. You can make it 0, frankly, or you could set it to 0.5, so anything that's 0.5 above. And if it meets it, then you keep it. You keep it in some set that you happen to make. And then once you found that, you march down, and as you march down, you just do the same thing. Does it meet this minimum score? And does the average score end up being within this threshold that I happen to have? And if it is, you keep it, and if it's not, you throw it up. And then you output the results into some set. So now what I'm going to do is I'm going to talk about how we applied it in a semantic querying thing, and I actually don't have the slides to show you this. We applied it to an HIV database where we search for people with certain patterns, and we're then able to get people who are very similar down to people who are not so similar, But instead, what I'm going to do here, I think in the interest of time, which I may have more than I realized, I'm going to talk about some of the work we've been doing in terms of trying to cluster patients by their treatment histories based on a LATCH score. And so the idea here now is that we have a database. Okay, we have a whole bunch of patients. They have certain treatment histories. We don't know anything about the treatment histories. Okay, and what we're interested in is finding out what are the common themes, okay, of the treatment. Okay, remember, all we see is that they have this kind of surgery, they have, this kind of chemotherapy, they have this kind of radiation therapy. That's all we see in some crazy ordering. Okay, so what we want to know is, are there common themes that are occurring? All right, in this case, in women who have stage 1, early stage breast cancer. Okay, and so ideally, what we like to do is that we like to create an interpatient similarity matrix, and then use that to cluster, and then see if we can examine the clusters and identify what sort of themes arise. We had to do a little tweaking here. The main tweaking had to do with the LATCH score to figure out what the score would be between treatment histories of two patients. Remember that what LATCH actually does is it finds all locally aligned segments between two comparison things. And so if I take two patients, basically, and I set, say, the threshold to 0, what's going to happen is I'm going to go something like this, okay? And so as a result, I'll get a bunch of scores there. And so the question is, well, how would I choose what the best score is, all right? And when you do it from a semantic query perspective, I would just choose, it would give me just, several matches within the same patient. I don't want several matches within the same patient. I want the representative one. And so we just, in this case, we chose the highest one, and we just said, well, let's just choose that, and let's weight this score by the ratio of the links between the two treatment procedures. Then what we did was, it turns out in the OncoShare database, we have access to more than 7,000 unique records in cancer registries. And from there, we identified 932 patients who were labeled with stage 1, stage 2, early stage cancer, and diagnosed between 2008 and 2009. And what we did was we went ahead and clustered them based on their similarity score, and then looked at the different cluster results based on recommended care guidelines from the National Comprehensive Cancer Network, which is a large consortium of hospitals that specialize in breast cancer care and have put out these guidelines for its management. The cancer registry has a bunch of coded data, essentially. And so in order to generate my treatment-to-treatment similarity matrix, I had to construct the ontology on my own. And this slide just basically details how I did this. You could take a term such as a modified mastectomy without unilateral removal of the uninvolved contralateral breast, and it has a reconstruction implant. And then from that term itself, from that phrase itself, it's fairly, you can basically infer that there must be some mastectomy. That mastectomy must include something called a modified radical. Modified radical can be unilateral or bilateral, and unilateral apparently includes a reconstruction implant. So if you go through each of the terms, the coded terms within the cancer registry, you can essentially create one giant sort of ontology, and that's what I did here. And then once I did that, I was able to take each of the terms, okay, from the cancer registry, and then create my procedure-to-procedure similarity matrix. For this particular study, what we did was for every unique treatment in the database, we ran latch on all the, with basically each treatment against everything else. We set the threshold to 0, and then we determined the maximum latch score and set this as our pairwise similarity score. And then we use a simple hierarchical clustering method based on the similarity scores, and we used a gap statistic in order to determine the optimal number of clusters, which in this case somewhere around 17, and it's the only reason I show this. What I'm showing here is basically a summarization of the data. There aren't 17 clusters here, and the reason is because just for presentation purposes, I took out anything that had less than 20 patients or something like that. And so I'm focusing on clusters that had a large number of patients for the most part. And what this shows is basically the cluster, the pattern, okay, based on the NCCN clinical practice guideline, that was associated with the cluster, and the percentage of people within each cluster that basically met that particular pattern. And basically, as you go down, what you can see is that the vast majority of these folks met clinical practice guidelines, met clinical practices that was consistent with what you would find within the NCCN, to degrees of anywhere between, I mean, really, it's pretty good. It's from 89% at the lowest up to 100%. A lot of these clusters were completely defined by the particular clinical practice pattern. And so what this basically shows is that this did a pretty good job of identifying specific patterns here. The pattern that's interesting that I list this in red is the pattern K. Surgery to hormone to radiation. This is a particular pattern. When you look in the clinical practice guideline, there's really no explanation for it. Okay, and so what we ended up doing was we looked at those patients. We basically went into the medical records with a breast cancer oncologist, and what we found was that first of all these patients were treated at Stanford, so that was interesting. The other thing was that all of these patients were consultations from geographically distant areas. So essentially, these were patients who came in and from Michigan or from New York or from Saudi Arabia. I mean, you can name it, anywhere. Okay, and what they were getting was they were getting consultations to Stanford because they wanted the best of the best. And what they found was that the hormone therapy was given as a prescription, which is why it got labeled by the cancer registry nurses as hormone first before radiation therapy. But when you read the notes, okay, all the patients within that group were told specifically by the oncologist, here's the prescription, okay, and don't do it until after your radiation therapy. And so what's kind of interesting about this is that our approach here identified a clinical practice pattern that, you know, when you just look at it, you think to yourself, what the heck's going on here? But what it addresses is it addresses real-world challenges that clinicians have to face every day when they practice medicine. So I'm going to wrap up here and summarize. I hope what I've taken away is, at least, you know, sort of my take-home messages here, is that, well, biomedical ontologies can be very useful in terms of making sense of complex electronic health record data. They can do it by standardizing its representation and its meaning. That treatment histories can be similar to each other, and they can be measured as such using biomedical ontologies. And what I presented here is a way of looking at similarity treatment histories based on their temporal ordering. And that this temporal semantic similarity measure can be useful, potentially useful in terms of discovering interesting anomalous treatment patterns from an epidemiologic perspective. I am not funded by R01. That's my advisor, Amar Das, who is also, the OncoShare project is funded by the Richard and Susan Levy. I am a VA Medical Informatics Fellow, and a stipulation of that is that I must always say that views expressed are those of the authors and not of the VA. And I'm happy to take any questions.